You're watching this because you have an abdominal aortic aneurysm, and depending on the type of aneurysm you have will determine how the repair is done. But for the most part, you probably have been recommended to have an endovascular repair, which is a minimally invasive way of repairing your aneurysm rather than a long incision from your sternum to your pubic area. So I'm going to describe to you exactly what an endovascular aortic aneurysm repair is. Just for anatomical purposes, this would be your aneurysm. Just so you know where these are, this aorta sits in your abdomen, in your belly area. It splits here about the level of your belly button, but this sits on your back, on your spine. These first vessels that come off the aorta as it comes through the chest go to the kidney vessels, so you kind of understand where the aneurysm anatomically is. So once the aneurysm gets to a certain size, typically about 5 centimeters or so, then it's going to be recommended that you have it repaired. Definitely for women at 5, men, they can sometimes wait till 5.5. An endovascular repair is a way where we don't have to cut you open, that will actually come in from the groins. Now, at the groins, it's one of 2 ways that we may access the blood vessel. We may actually make a 3 or 4 inch incision, get to the blood vessel, and then repair it from the inside. Or you make no incision at all, and it'll just be little needle holes, which is marvelous if that could happen. But again, versus a long incision in your stomach compared to 2 small incisions in the groin, it doesn't change the course. You pretty much will stay in the hospital one night, barring that there are no complications. Okay, so how's an endovascular repair done? We get access to each blood vessel in the groin. If you're this type of aneurysm where you actually have a neck, and this is considered the neck of the aneurysm. You have at least 15 millimeters distance from the kidneys to the start of the aneurysm. You will have this form where the stent graft is all below the kidney vessels. So basically a stent graft will start below the kidney vessels and extend down to your pelvic arteries. All right, if the other one, which is a little bit more complicated, if your aneurysm starts high by the kidney arteries, all right, and there's no room, you don't have this neck, well then you need a special type of stent graft, which is only made in Australia, and it takes approximately 3 weeks for it to get here. All right, this particular graft, they use radiology studies to look at your aneurysm, and they'll design a stent graft just for you. No one else in the world can use that stent graft. What they do is they design it so they make these holes that align to your kidney vessels. Now, on this diagram, we always show the kidney vessels at 9 o'clock and 3 o'clock, but everyone can be different. Some could be at 2 and 5 o'clock. Some could be one higher than the other. So everyone's a little bit different. But in order to do that, they actually have to create this stent graft designed by those CAT scans specifically for you. Now, after that's done, they send the stent graft over, then we'll set you up for surgery. From there, again, we'll get access from the groin, and we'll deliver the device up into the stomach area, align the 2 fenestrations to the kidney vessels, and then deploy it. And then from there, once we know that we have deployed that, we actually will secure it by putting 2 more stents from here into the kidney vessels. So that way it doesn't move. After we have that done, we deploy the rest of the stent graft down into your pelvic vessels. So that's called a fenestrated stent graft, and this is your standard typical infrarenal abdominal aortic aneurysm endovascular repair. So that all said and done, a lot of times the procedure itself is very easy to do, and you can get it done easily. The things that you need to be concerned about is what could possibly happen afterwards. One, obviously, if you cut into the groin, if your vessels in the groin have a lot of plaque, you can actually lose blood flow to your leg. Well, we would know that at the time of the surgery. You're not going to come off the table with no blood flow to that leg, but you may end up needing an incision in order for us to repair that artery in the event that the plaque that's in your vessel there blocks the flow to the leg. We'd actually have to take that plaque out and repair that artery. We would do that before you even come off the table. Number 2, things that will happen possibly and follow up. They're called endo leaks. Okay, just so you know, endo leak. Now, people hear the word leak This is not like blood that's leaking outside the vessel. This is blood, an endoleak is actually leaking back into the vessel. And how does that happen? Well, if a blood vessel that comes off of the aorta, these are blood vessels, if blood flow comes this way instead of going out, it's called an endoleak. Type 2, this is called a type 2 endoleak. Type 2 endoleaks, we can pretty much watch for a long time. For most of the time, they don't affect the size of the aneurysm. In the event that a type 2 does cause increase in growth, then we may sometimes have to go in and coil that vessel so that you don't have any blood flow into the aneurysm. Or sometimes we can actually put coils into the sac or glue so that it cements the sac so that no blood flow can come in. Again, a lot of times the type 2 endoleaks we can fix all done through minimally invasive techniques. That's a type 2. Now, type 1 could be where blood will come down this way, but it also gets between the stent and the wall and comes in this way, and that's a type 1. That can make this grow very fast. So those, if you happen to have a type 1 endoleak later on, a month or 2 months, 3 months, 4 months later, that's going to have to be repaired immediately. Otherwise, it'll make the aneurysm grow fast. The other one is a type 3, which is actually through the stent graft. That also has to be repaired immediately. And then there's type 4, which you don't necessarily need to be concerned about. That's usually through the pores of the graft. But that's why we will do CAT scans periodically throughout the year, your first year, and then yearly after that to look for these type of endoleaks. All right, so that's about the risks that you need to, or complications that could possibly happen. If you happen to have any sudden abdominal pain, sudden leg pain after your surgery, whether it be a week or 2 months, 3 months later, notify us right away. Go to the emergency room and have the doctor call us as well.